room. We welcome you. Yep, flooding in there. Definitely familiar with my voice, so I'll just give people a moment before we do our formal introduction. Being reminded that my voice is a little quiet, so I'm just gonna yell at everybody. Hope that's okay. It's a way to start, right? It's 11:01. We started just a little bit after 11, so I'll give people another wee moment, and then we'll do our formal intros. And if people come in a little later, that's okay too. That's fine. I think we'll start, folks. Okay, so let me get my little script out here. So, hello, everybody, and welcome. We're glad that you could join us today for this important conversation titled Integrating Lived Experience into Psychiatric Education. This session will explore how bringing the voices of people with lived experience of psychosis into medical training can deepen empathy, reduce stigma, and improve communication in clinical settings. Our panelists, drawing on work from Emory University, will share examples of how this is being done, as well as the challenges that come with it, including ethical concerns and institutional barriers. They'll also offer strategies to support meaningful, sustainable integration of lived experience in psychiatric education. So we encourage you to participate actively. The chat is open for your thoughts and reflections. And of course, as always, we'll have a Q&A at the end. But please keep the questions flowing in, and panelists have welcomed them to just hear from you and deal with them as quickly as we can. But we will leave time at the end for discussions. Also, our good panelists are going to introduce themselves, so I'm going to leave that with them as I pass it off perhaps first to, I understand, Dr. G. And these lovely people are all the way from Georgia, and we understand that it's nice and warm and balmy down there. So I'm here with Tracy in Vancouver. It's a little bit chilly over here, so we're just a little envious this morning. And Dr. G, over to you. Take it away. Thank you.
Sure. Well, thank you for the lovely introduction. Thank you for the invitation for us to join everybody today. I think we're just going to start off with very brief introductions about ourselves, and I think Justin will do a sort of a broader introduction for what we want to cover today, and then we'll kind of hop into it. We definitely welcome engagement as much as we can. I know that we're limited by just the written chat, but please put questions or thoughts or comments in throughout the course of the session today. But very briefly, my name is David Goldsmith. I'm an associate professor in the Department of Psychiatry and Behavioral Sciences at Emory University in Atlanta. I am a physician scientist. I spend my time sort of split between doing research and providing clinical care and teaching as well. I am the co-director of our clinical and research program for psychosis at Grady Hospital and run what we call the P-STAR Clinic, which stands for Persistent Symptoms Treatment, Assessment, and Recovery, which is a recovery-oriented and focused clinic with a specific emphasis on using clozapine as a way to help people sort of get back on their feet and work towards recovery. So I will maybe I'll pass it on to Will in order on my screen, and we'll go down the list.
Everybody, I'm Will Hiltman, born and raised here in Atlanta. My story is basically had a great childhood here. Got into performing arts, middle school, high school. Took a gap year, went up to NYU, had a little bit of experience with cannabis and a few other things that led to manifestation of bipolar. Dealt with that through college. Let's see. Then 2016 graduated. Then I've been here since then. Got involved with NAMI. That helped a lot. My family got involved with NAMI, did all that they could do, and we've been involved. I've been facilitating groups with them and trainings and such. and getting back into what I went to school for, which is acting and performance. I've done a number of community plays over the last 5 years. So I'm getting back into that, doing both acting classes and actual performances. Clozapine has helped a lot. It's been a steady, gradual improvement since about 2014. And what else? Yeah, doing a part-time job and really focusing on a current show that I'm in right now.
Thanks, Will. Dion?
Hey, so I'm Dion. I've been seeing and working with Dr. Goldsmith since about 2016, I believe. And my mental health challenges started to come about around the age of 19 when I went away to college. And so basically, I started getting treated for treatment-resistant schizophrenia. So I also am treated with the drug clozapine. And, it was one of the ones that have worked wonderfully for me with the least amount of side effects. I want you guys to look up this word, agnosagnosia. I did not have insight into my experience of dealing with major depression and schizophrenia. And I had to kind of, over the years, grow into the knowledge that, okay, I have, this experience. And every single day, I'm getting better and better at, learning more about my experience of living with psychosis. More about me is that I love to write music, and I work as a behavioral health assistant for the Superior Court. I wanted to work with college students, but instead, I'm working with the court system. So thank you for letting me share.
Thanks, Dion. And good morning, everyone. Good day. My name is Justin Palanci. I am also on the faculty here at Emory University in Atlanta, colleagues with David Goldsmith, and I consider both Will and Dion also colleagues in our pursuit of teaching psychiatric trainees about psychosis and working with people who experience psychosis. I am the medical director for our Assertive Community Treatment Program at Grady Memorial Hospital, which is a safety net hospital for the city of Atlanta. And perhaps David mentioned this, but we are co-directors of the psychosis course for the psychiatry residency, which kind of leads us into the reason we're here today. So we had a chance to meet Tracy last year when the four of us were presenting in Pittsburgh at a conference, ISPS conference, about this journey that we've been on together, about how do we incorporate people who have lived experience with psychosis into the classroom and into other teaching settings to both enrich our trainees' experiences. And I think it's been a really meaningful process for the four of us as well. So we're going to spend some time chatting about that, kind of reflecting on that a bit. And as Regina mentioned at the beginning, please, as questions come up for you or things that resonate with you, let us know, and we'd be happy to dive into that a bit further. So, David, do you want to sort of set the stage a bit about kind of how this came to get started?
Yeah, I before I go into that, I do just want to say, we I think it was mentioned initially, maybe Justin, you had said it, that this is sort of an ongoing reflection and conversation, and that really kind of struck me because I really I really feel like that's true. And this has been a journey that the four of us have gone on together for a number of years now, and um we've gotten to travel together to do this. We've been able to teach a lot of people throughout the years, and each time we do this, I think we learn something different about ourselves and each other and the process. And um I think I've said this before, but I am truly grateful for that. And of all the things that I feel very fortunate to get to do as part of the work, this is one of my favorites. and it really has been able to sort of shift the relationship that I feel like Will, Dion, that we have with each other. Honestly, the relationship that Justin and I have with each other, and to be able to grow through that process. So I do want to acknowledge that to start, and honestly say thank you. You know, I've been thinking about psychosis and teaching about psychosis for many years. I started doing work in this area back when I was in college, and have been doing research to some extent for over 20 years in this space. And when I joined the faculty at Emory and was given the opportunity to do more teaching about psychotic illness, I was increasingly finding that something was missing. And the more that I reflected on it, and the more that I worked in the space and got a chance to really help people sort of on that path of recovery, I really came to the realization that something was missing, and that really was really the voices of lived experience. And I can talk for hours about what psychosis is and what the neurobiology is and how we treat it and whatnot. But at the end of the day, I really have no idea what it is like. And I think that became a conversation that Justin and I found each other having over the years when we started to work together and get to know one another. And finally, we said, why don't we do it? Why don't we invite someone to come join us? And so I was actually trying to remember exactly when that first time was, but Will came and joined us. We invited Will to join us for a session with some of the I think it was with some of the residents that first time. Although we've done this with medical students, we've done this with some of the psychiatry residents, and it was remarkable. I mean, I think that we really realized how useful this was for the education of our students and our trainees. And we asked Dion to join us at one point. We were very fortunate to be able to give grand rounds for our department at Emory, where we were really able to, I think, elevate the voices of individuals with lived experience. And I think that there's still a lot of work for us to do in this space. But I would say we've been on this path for a few years now, and I think that increasingly we have I think exposed a lot of learners and trainees to what the not just what the experience of psychosis is like, but again, what it is like to live with it, and how to recover with it. And I think that's really enriched sort of the experience of the trainees who spend a lot of time on inpatient units and in emergency room settings where, they are, for better or for worse, really faced with very acute and decompensated cases of psychosis. And that becomes the face for what this is. And I think through this process of teaching together with Will and Dion, I think we have helped to shift that perspective, which I think has led to actually a lot of trainees being very interested in going into working with people with psychosis, especially in the outpatient world, and really having a recovery orientation, which I think we need a lot more of. So I think maybe it would be helpful, Will and Dion, maybe to hear from you a little bit in terms of what the experience has been like for you all, in terms of what it's been like to teach. I know that we have a lot of things to explore in that space, but maybe we can just start broadly of what that's been like for both of you.
Well, for me, the experience of teaching for me it feels like giving back to a system that has definitely been there for me, giving back to a system that it feels like just putting kind of like a little stamp on, okay, I'm a person with lived experience. I'm a person that has experiences with psychosis. This system has helped me so much. So now let me play my role. Let me play my role as a giver. So it really feels like a sacred responsibility, to continue to have teaching opportunities with my doctor, and even just opening up just the voice of lived experience. And so from my end, it feels like charity, it feels like giving back, and it feels very meaningful.
Yeah, I'd agree with that. Definitely getting a chance to give back. And also, some of those experiences were pretty tough. And so the idea of being able to help potentially improve things, make things be a little bit easier for those who come after me and us, have a little bit more humanity. Those can be tough experiences in those hospitals. On some level, you gotta help somebody if they're in the acute phase, but to, as much as possible, not have it be so intense and rough and difficult, but to try and help move it towards something a little bit more nurturing. Help again, give back in terms of being able to explain how it feels to be in those experiences, whether it's in the hospital or needing to be in the hospital or, operating on your own. Just all of that. Yeah, wanting to give back and trying to improve things, trying to help things out to make it a little bit easier for those who come after.
And I would say too that the hard parts of psychosis, it makes you forget about the good moments. So, when I'm there, helping to teach, or when we did grand rounds, that's like a stellar experience. That's something that, that puts a smile on my face. And so, while psychosis can have moments where, it'll kind of block out some of the good experiences that you have, or the good experience that you used to remember even as a child. Having the opportunity to teach from my doctor, that puts a smile on my face, and it brings positive memories into play.
I'd throw out also being able to have that open communication and connection, to feel like it's very free and you can share what's going on. That's one of those times. And I think that applies to these presentations too, for the most part, being able to be a little bit more, open about some of these experiences. So that can be healing.
Yeah.
Yes, and I wanted to say one more thing too. Me and Will didn't know each other's before grand rounds. And so since we're both a part of the Peace Star program, it was so relieving for me to finally meet someone else that was going through the same, getting treated by Dr. Goldsmith and a part of the Peace Star program. So, I piggyback off what Will said, very, very, very beneficial.
I'll also add, that, Will, you mentioned this idea of being more, these spaces create more freedom to talk about some of these things. And, one way that we've often framed this conversation, especially for the trainees, the residents especially, is an opportunity for them to feel more open to talk with both of you about this. And, we've had, I think, some pretty interesting conversations over the years with some of the trainees, but, so often when you're taking care of someone, whether it be in the outpatient or the inpatient world, we as providers often feel somewhat limited by what we can ask of what the experience is like. I'm not sure that's necessary, to be honest, but at the end of the day, I think that we often feel some restriction in how, how deep we can get into the weeds with somebody. And I think that these, I've often sort of, I think, jokingly said that, it's like, being able to ask all the questions you've always wanted to ask your patient that you've never had the opportunity to before. And I think that the feedback that we have gotten from the trainees has been overwhelmingly positive because of that ability for them to feel more free to ask questions, but also I think they very much pick up what you were saying, Will, and I think Dion, what you were echoing, just how open you both have been with them about your experiences has been really helpful.
Yes, I want to advocate for dual relationships in every field of study. Dual relationships with your dentist, dual relationships all across the board.
I really want to eat a lot of candy with my dentist. That feels like a good idea.
But and I'm curious, what do you, because I agree with the sentiment that I think that we've gone to places in these conversations that are like really genuine, and there's no, very little sugarcoating going on, and you all have shown up. You've been really, present with your stories. What has facilitated that? What has allowed for that to be the case? Yeah, I'm curious about that.
I mean, trusting that these interns and residents, they're going in to be doctors. They're gonna, you know, they're gonna respect your vulnerability and what you're sharing. I throw out on some level, yeah, it's a little bit different. Like this is being recorded, so this could be to a much broader audience. And then on some level, yeah, there's stuff, it feels a little bit more vulnerable but safe with a doctor than necessarily with just another lay person. So having that knowing that they're going into this, doctors go into it to help people, and that they're going to respect the lived experience, and that's going to be safe sharing that with them.
Yes, for me, sharing lived experience with me, it kind of helps me put pieces of the puzzle like to life about things that I haven't really thought about. So for me, every time that I share, it's putting pieces that I might have not thought about in a long time. It really just puts things into place and helps me to reflect and help me to just have that introspection.
And I'm kind of curious, has it impacted? I know, when you're back in the clinical setting and you're interacting with trainees, or maybe you're meeting with trainees for a clinical visit, do you think these experiences have had an impact on the way those conversations go? I mean, have you? Yeah, I'm wondering.
Yeah, I mean, again, just feel I could be even more open with them. I guess with each opportunity, it allows for more trust and the relationship to build.
Yes, because I've seen so many student doctors, right? Ever since I've been working with Dr. Golden, I've seen so many student doctors. It definitely made me more free with sharing my story. And it breaks down the walls of stigma. Because a student doctor will go into the session, and maybe thinking one thing, and they might see another thing. So I definitely think that I think that the work between like as early as possible, having future doctors have interaction with people with lived experience, I think the better.
Could you say more, Dion? Sorry, could you say more about that, Dion? Like go in thinking one thing and kind of find another. Could you say more about what you mean?
Yeah, because in a patient doctor setting, sometimes things can feel like an interview. You're getting asked the most important questions. Do you have thoughts of hurting yourself? Thoughts of hurting anyone else? And when I would see student doctors with Dr. Goldsmith, there was no pressure with it. Like it was like while they have to ask those questions, and they get that live experience of it. I feel like that it's richly rewarding because we're talking, we're going through these questions that have to be asked, but I feel like that there's like a certain, I guess, I don't know, they're getting like the real deal.
I think that word stigma for sure. That's still something. I think it's going to be a way. We got a few more years to work on that. You know, what do they call it? Like mad pride or something, you know, the movement of respecting, you know, mental illness, mental health. I think that's going to be the next one. So yeah, stigma. And I guess that's kind of connecting to what you're saying in my mind, you know, meeting with these student doctors, you know, it's a place where the stigma can kind of get lowered.
Yes.
I'm really struck by this. I mean, this is sort of an area of all this that we haven't actually spent much time exploring. You know, we focus so much on the classroom teaching that we've done together, and I haven't really thought about what that experience must be like for you both when you come into the clinic. And, you know, our clinic has a significant number of trainees, both medical students and residents. And, you know, I I've often been of two minds and have had mixed feelings about this, right? On one hand, we get to expose all of these people going into medicine and going into psychiatry, medicine broadly. Some are going into surgery, you know, to people like yourselves that I think really does help to destigmatize serious mental illness and really I think allows them to see that, you know, people may have a diagnosis attached to them, but at the end of the day, you're Will and Dion. And I think that that's so important. On the other hand, I think that I feel bad sometimes, right? Because you know you come to see your doctor and you know you're being kind of forced without actually getting an option to see people without much training and experience. And um, you know, I think we thread that needle pretty well. But
Can I jump on that?
yeah, please. I'm just kind of
Yeah,
talking.
no. You're so in the word partnership, you know,
Yeah.
it is a different relationship than I guess just a standard patient and doctor. And there are pros and cons to that. It's like, you know, I think one of the pros is definitely we get more time with you, we get a little bit more attention, we get a little bit more, you know, person to person kind of communication.
Yeah. I wonder for both of you, how has I mean how you talked a little bit about this, but that experience of teaching um you know, has that shifted? I mean, there's always been trainees in our clinic, right? And we haven't always taught together. What I'm curious sort of like how your experience has shifted and how much of that comes with the teaching, how much of that comes from just being in the clinic for a long time now and just kind of knowing what the gig is, what the experience is like. I'm curious what role the teaching has played.
As far as with the student doctors
Yeah,
or
your experience of then teaching from that clinical standpoint. Because I do believe that when the trainees work with you all in clinic, you are very much teaching them.
true,
And in fact, I think I've probably used that language at times, and I think I've asked both of you at times for feedback in front of the student of how they did, uh,
right?
and you've both been very gracious in giving that feedback.
Yeah, and you know, because it's like for me, I have like such a hunger for well-being. You know, I have such a hunger for just figuring out my own experience and living with psychosis. That you know, when I would teach with you, and we would have the student doctors in there, you know, I'm telling myself in the back of my mind, like, okay, this is going to make me better. But I could imagine for a person, you know, who's not there yet, that you know, it would probably be, you know, I would say that the dual relationship of teaching, I would say that a person would have to be open to that experience and definitely, you know, not forced upon them.
That's interesting.
What's popping up for me is just the opportunity to share my story, and how how, it can almost be fun sometimes. Old friends of mine, they know some of what I've been through, but, it's not the same kind of thing where I can be talking about anything and everything that I've been through. So it can be, yeah, almost like, yeah, just sharing the story and again, having that opportunity to talk about stuff that I don't always get a chance to talk about.
And this has been a long-term work, Dr. Goldsmith. Like, I'm thinking I was like mid-20s when I first met you. So just in the perspective of healing, I would say that I believe that, people with psychosis, that they do need to be teaching, because everyone does have questions like, what is it like to live with this? And, what role could a person that's living with this illness, what could they tell us some things, that we don't have insight in? So, for the ones that live with this experience that are willing to share, I think, we should definitely be drawing out that information from them, because me and Will, we have some similarities in our experience, but I would imagine that there's some things in our experience that are not the same. So each person is carrying, some jewel there, some jewel of insight there that they can help give to like the greater medical community or academia, whatever.
I was just going to throw out, just some of the experiences, some of the broad experiences, delusional thinking that I've had lived experience around. So stuff, pretty commonly understood, the movie Truman Show. So some of that, self-referential thinking that's kind of similar, grandiosity. Those are some of the main ones that pop up pretty early on with many delusional experiences, psychosis.
So, I think what's striking me in this conversation is, and hopefully it's pretty clear to the audience. I mean, there's so many powerful reasons to include people with lived experience have them as teachers, both in and out of the classroom, right? And I'm kind of wondering if maybe we could talk a bit about the challenges in doing that. I mean, I think we've been able to do some really cool things, and the work is ongoing. But I think it would be useful to talk a little bit about the challenges. And so I wanted to point out, two. One was the idea of kind of creating a cultural shift, I would say. I don't know if David, if you would label it that intensely, but this idea of like creating a culture around having people with lived experience like in the classroom. And David and I, as the course directors, have a lot of leeway in sort of the way we plan the course, etc. But I mean, I think getting the buy-in from the department to have us present at grand rounds was a big deal. And I think there's like sort of little pushback along the way that we've had to sort of demonstrate and kind of prove the concept out. And David, I'm curious what you would say about that. But and I also want to throw out another challenge, which has been, Will and Dion have volunteered a lot of their time to participate in this work and do this work. And I personally don't think that's right. We've actually advocated for it, have been able to get a small amount of funding to provide some funds to Will and Dion when they give their time to teach. Because my stance is, when I teach at the medical school as part of the department, I'm paid for my time. When I'm sitting in the classroom with students, I'm paid to be there. And Will and Dion have so much to offer our trainees, and I feel they should be compensated for their time as well. And so that was we got a lot of pushback navigating that, and then we were able to again secure a bit of funds for that. But anyway, David, I'm wondering what your thoughts are as I kind of shift the conversation a little bit.
Yeah, I mean, I think that I think those are two different topics, but I do think that there is a thread of the culture shift inherent in both of those questions and or ideas. And I do think, at least for the psychosis piece, we have created a culture shift. I think that, we bring, I think we do at least 3 sessions with the residents, with people with Will and Dion. We do one with the medical students. And I think that that has really led to a real interest in this work. I mean, I sort of said anecdotally, the feedback that we have gotten has been extremely positive. But for example, in our clinic, this upcoming academic year, which starts next week, we have 6 senior residents who have chosen to do electives in the clinic, which is unheard of. I mean, most years we have none. And there may be a number of reasons for this, but I do believe that this aspect of teaching and elevating Will and Dion and others' voices, both in the classroom and then also in the clinical teaching as well, has led to people really craving more of this and more of this sort of model of care and model of teaching. With that said, I think that there are still ways that we need to go. I think that I know Justin, you and I have talked about having someone be present with us at all of our sessions, right? So if I'm teaching about neurotransmitter systems and neurobiological pathways, underlying psychotic illness, we should have someone there to talk about that, or at least to reflect upon it. I would love to see this outside of psychosis, in the other types of psychiatric illness that our residents and our medical students are exposed to. I think that, we had sort of fantasized a little bit that this grand rounds that we did might be a yearly thing, that every year someone, maybe it's around OCD, maybe it's around bipolar disorder, around depression, around PTSD, whatever it may be, we reserve a grand rounds for the department to bring in people with lived experience, as opposed to just people with clinical or research expertise. That hasn't come to fruition. Now, I am now running the grand rounds committee, so maybe we can make that happen. But I think that there are still a ways to go. I also, to just comment on the compensation piece, I think that this has been a long-standing goal of ours to try to get something to acknowledge Will and Dion's time. And I was surprised, to be honest, at some of the pushback that we received. But of all people, who was the one who eventually said, yes, like, here's money to do this, it was the chair of our department. Like, the head of the entire department of psychiatry saw the value in this. And I am incredibly appreciative of that. And I am glad that, yeah,
and it was
please.
following our grand rounds, really. I think
Yeah, it was.
kind of inspired by our grand rounds, and yeah.
Yeah, and it wasn't like let me look at the budget, let me think about where we can pull funds from. It was, yes, of course, how much do you need? And we had funds the next week. But with that said, it's still, I believe, still just an acknowledgement, a token of the gratitude that I think that Justin and I have for Will and Dion and others who have done this. And I think that we need to keep pushing and working for more, because, like Justin says, we
It's
get paid for
appreciated.
this. Well, I'm glad, but it's not enough, Will. I mean, you both have given so much of your time. And I think one thing that
Well,
Justin, you have talked about in the past is actually, like, this is your area of expertise, right? I think we have used that word, right? Like, I get asked to give talks about my research and I get paid for that. That is my area of expertise. why aren't we treating you the same way?
Dr. Ghost, I was going to say, like, just like from my perspective with lived experience and incentives into like being in the classroom or being, teaching in any capacity, for me, and I don't know how this looks, but I'm just throwing it out there. I would want something that would the incentive to be something that will further my recovery or kind of further, my direction in life. It would have to be like an incentive that would like further building my life in some capacity.
I'm actually curious about that because I say all this, Justin has said all this, but we've never actually asked you guys what would be good. What would be an appropriate compensation? I don't need a dollar amount here, but is it money? Is it gift cards? Is it, like you were saying, Dion, something that furthers your recovery? What might that look like?
One thing that comes to mind for me would be like, I guess like, but Grady Hospital pretty much takes like different kinds of insurances, but maybe there could be some kind of incentives of someone getting treatment, without having to, maybe they can't afford medicine or whatever, but, something that would just, that would help the person to kind of continue being treated. And then that will also be an incentive that will push them in the direction of, I don't know, progressing in life. But I think it is something, to think about, what kind of incentives would really be meaningful, to someone that would share their experience.
Will, any thoughts about this? Or I'm curious from both Will and Dion, your other thoughts on any challenges that have come up in being involved in this work.
Yeah, so being part of NAMI, I've been an admin assistant for our affiliate for a while, and I was really championing, any of the people that have learned any of these programs or, are, involved regularly to, give them a stipend whenever they go do anything, essentially. Be more along the lines of compensate them, and then then we'll have more more people see us, and then the thing will grow. Unfortunately, and again, this is away from Emory, but this is NAMI. Unfortunately, I'd say this last year and a half, they wanted to safeguard the money that we have. And so, but again, addressing the same thing is like to have an organization that says, okay, you have lived experience. You're going to go give a talk, especially if you've been trained to do that. You go give a talk. Yeah, we'll give you $50. And then they'll be incentivized to go find other places to talk and to bring more people in. So that's the idea I had for NAMI. And I think it's still possible, but I'm going to have to work on that.
So we're at the 45-minute mark. Do we want to potentially open it up for any Q&As? We can keep any questions from the audience, or maybe we can invite people to start to write in any questions that they're having, and certainly can also keep the conversation going. But Regina, any thoughts?
Well, Justin, thank you for the opportunity to just bring Carol's comment forward. I'm not sure if people can see the chat, but she notes that she's struck and inspired by the honesty and openness of the patient-physician dialogue. She says she's not a clinician, but a mom of a 25-year-old who had a psychotic break while on full scholarship at grad school. 9 months, and he continues to spend days in bed with little hope and little insight, and not only his relationship with psychiatrists, time caregivers to influence his culture and care feels extremely limited. I so wish something existed like this in Vancouver, Canada. And she says, thank you for your courage and contribution, Will and Dean. That was so articulate, and I had to go out to you that you're not as connected with the team as you would like to be or feel is beneficial for your life.
Yeah, and 100%. And I would say, I think the other thing that has been nice about our work with Will and Dion is that there have been times when, well, we've met both. I've met both Will and Dion's parents, and Will's dad actually participated in a session with us one time, sort of somewhat reluctantly from the back of the room, but I think he wanted to chime in at some point, which was so awesome. But I think, in parallel with this work that we've been doing, I've been trained in something called open dialogue, which is about incorporating families and people's support networks into their treatment, and I think that's been a voice, or sort of a value system for me as we've navigated this work. But Will, I don't know if I know you can't speak on behalf of your dad, but I mean, what's it been like on those instances when your dad participated in the teaching sessions?
Yeah, so when Regina was talking, it cut out for a second for me, but just going, I'm totally fine for the most part with my folks um, being part of, mental health journey, growing in functionality, stability, and all that. They did a lot of work. They've put in a lot of effort to support me. And yes, they have a perspective that other people need to know too. The family members, that's a very important perspective. So in NAMI, we have, you have your family support group for family members and caregivers, as well as peers, connection support group. And they have classes for both peers and then separately family members. And yes, they have a perspective that needs to be known. Examples would be, yes, just that from, when 2009, when things started to manifest, it was not until around 2014 that they got involved with NAMI and, taking those classes, and how they wish they had gotten a part of that sooner, to understand what other people have been through, to get some tips and tricks and understand that it's a marathon, not a sprint. Everything from that to, Dion throwing out the anosognosia idea that, I didn't have insight into what was going on for me. Having to learn to trust their perspective over my own truth, what I perceive to be true. So that things like that, the book, I'm Not Sick, I Don't Need Help. I think that's Amador. Listen, empathize, accept, and then partner, all these things. They've learned tons and tons of things. So it's not like I want to try and completely separate and detach from them. They have a lot of stuff to share too.
And I think that message is so important for our trainees to hear, and also learn by example, in the way that we model the way we go about care. Dion, I wonder if you have any thoughts.
Yeah, I would say that for someone dealing with a family member that might be going through psychosis, or going through a family with we'll just go with psychosis. I would say, to just know in your heart that it's not a hopeless scenario. And I would say that feed on education, educate yourself about the person's experience, educate yourself, get with some of these groups, like Will said, NAMI, he threw NAMI out there. And don't reinvent the wheel. Learn about what's already been put out about people who might have agnosia and don't have insight, into that they're going through a psychosis. And then I would say too, do your best to help restore that person's sense of community, because that's a very big piece of it as well. And then, just the knowledge that's out there already on, helping someone, search for it. The power of connection is so powerful. So yes, searching out the information that's already out there on that.
John, maybe we can just have a touch base here with Robert, who said the difficulty in British Columbia here and most of Canada is the lack of full understanding of sharing of information legislation that impacts how much info clinicians feel that they can share, which impacts how families are involved and how they can participate, and the treatment of loved ones. He asks, has this been an issue in Georgia as well?
Yes, yes, it is an issue, and of course, it can be very complicated. But a couple key things, um, you know, patients always have the opportunity to sort of to have to opt in or out of having their family involved in their care, right? But I think that the clinician and the system's stance on family involvement has a big impact on how a patient feels about this. And I mean, we could have a whole session on this alone, by the way. But quickly, I'll just say, so I like to take it more from a stance of, this is part of what we do, and if you want to opt out, it's more of an opt out than an opt in approach, as opposed to, would it be okay if? I mean, this is a part of what we do, right? We get to know you, we get to know your support system. I work in a community treatment program, so I'm out in the community, I'm in people's homes. Mom is usually listening from around the corner. So I say, how would it be if mom sat down with us and we had the conversation all together? And maybe we don't do that in the first meeting, but we work our way up to that. So yes, I mean, we certainly, and there are a lot of, hospital systems that use HIPAA as a barrier, that you can't ever have any contact with the family at all. And I think it has been misinterpreted and it's overused. And I think, obviously people's health information, they have a right to privacy. And I think the system has sort of found a way to systematically exclude families from their loved ones' care, and to the detriment, I think, of everyone, especially the person at the center of concern. So yes, we do have to navigate it. Yes, it's challenging, but I do think that clinicians' comfort level with working with families and a belief that it is important, those things, a shift in that way of thinking can have a big impact on how families get incorporated into their loved ones' care.
Yeah, I would echo that completely. I try really hard um, to make it sort of, just like Justin was saying, like part of the norm, that families being involved is what we do. I mean, I think I've had both Deanna, Will, both of your families have been involved in some of your appointments. I will add to the barriers too, is that I think the system is not always set up to allow for time, and in some cases less so for us in the system that we work in, but compensation, that creates a barrier. So if I get a phone call from a patient's mom that I know is going to take 30 minutes to sort of talk to them about what's going on, many people will avoid that or say, I can't talk to you because of HIPAA. But whether it's conscious or unconscious, I think some of that is just there are systematic barriers that are keeping that from happening. And so I think the more that we can just make this part of the norm, I think it's going to be better for everyone. And to come to a better understanding of where someone is on their journey. I'm curious, Deanna, Will, from your perspectives, what that's been like for you.
Yeah. So I had a very, very I would say hands-on mom in my recovery. Very hands-on. She wanted to be a part of it. She wanted to show up to appointments. There were a couple appointments where I had to tell her, I got some private stuff I need to talk about, so you need to sit this one out. But I would say that family involvement and family education is crucial, and there are so many barriers to to having that hope, that family support, and to bridge them into the treatment. But I would say, me at the beginning of my treatment, I wasn't for it, but as I progressed in my treatment, I'm like, okay, let's include my mom into treatment. Let's let her have input. It had to grow on me as I got further and further, into wellness.
Yeah, similar. Parents involved, mom very involved. You know, had rules for me, you know, living with them while I was recovering. You know, don't harm them, don't harm myself, don't harm property, take my meds, let them be a part of my medical team. So often going to appointments with me, at least, you know, allowing them to have access to things, signing off HIPAA. And that was very helpful. Simultaneously, that we had grown up pretty good communication and all of that with each other growing up. But on the other hand, they had to be a little bit. They had to have some tough love of saying, you know, these are the rules. You know, you got to be taking your meds and all that, and you got to let us be a part of this mental health journey with you.
So, folks, I know that we're coming to a little bit of a close. Maybe we could just hear from Robert, who says, I'm thinking that including more in-depth training in the physician training work around the release of information to families and others on the continuum of care is foundational piece of improving treatment for loved ones experiencing illness. Also for the social worker and the nurses as well. So for the whole healthcare team having ongoing training. And I think my experience here in BC is that really it's a little bit site dependent on how that happens. And perhaps that's true of overseas as well. I would like to just take your attention to a document that Tracy kindly posted, something that might be of help to you. So there's just our current guidelines. We think that's the most current guideline around how compensating individuals with lived experience for their work. And so it might just give you a little bit of meat and potatoes. I'm Irish, can't help that. As you go to your good organization seeking support for that work. And I had another thought, which ran out of my head, I think. Tracy, do you know what I was thinking? I bet you do. It is 11:57 though, folks. So maybe, Tracy, maybe we should just say a big thanks to everybody. A reminder about the conference, the upcoming WAPR conference here in Vancouver that's happening in September. So we'd love to see you there. Just reach out to us if you'd like more details. I just want to say a sincere thanks to the panel for this work. My background is in occupational therapy, and we've tried to, at UBC here at least, bring persons with lived experience to the classroom. And I too have found it a really wonderful learning experience as well. We've tried to engage a number of different people in that work so that we can just hear different perspectives, because of course there are many corners that people experience and share. I concur with the comment who said that they're really impressed just with the openness and the sense of a deep respect you each have for you. I will leave you with a thought. I'm not sure if you've published this work already. I am looking for a nod. Perhaps you have, but I think dear Dion has given you a wonderful title perhaps for your next paper when he talks about hunting for wellness. I think that's just a impactful way to think about this work. So over to you for last comments. Anybody who might want to just close with thought.
Well, I'll just say, we've been talking about writing about this for quite some time, and we need to make it happen. So that's an extra motivation to hear that feedback from you, Regina. And quotes like that from Dion and from Will today and in other conversations is the reason why I feel so privileged to be involved in this work with them. So thank you so much for having us, and to the audience for your attention and participation.
Yeah, echo that 100%. Thank you all.
Yes.
Thank you so
for
much.
the opportunity to share. Appreciate y'all.
Thank you. Awesome. Thank you, dear colleagues. Great work.
Take care, everyone.